Running a perfect world, the chapter would just be 1, 3, 5, 6, and 7 on the test. 1, 3, 5, 6, and 7. That's what will be on the test if we can get them all in. So that's what we'll be shooting for. But I'll make sure to clarify that. We'll see how far we get. Okay, I'll just leave this little crack. Well, I will tell you that we have the course calendar and we do go by it, but I can tell you for whatever reason I tend to get behind and then I'll get caught up at the end. So just keep looking at the course calendar and mark off the chapters that we've done. And if we're behind, just figure out where where we're at. But we may be behind what it says on the calendar. But I promise we'll get caught up by the end. We always do. Somehow we get behind and get caught up. So I'll try and keep you in the loop of chapter 2 and what's going to be on the next test. But it may be that we run behind. There's a lot of material. I could teach OB for a whole semester. Literally, I could easily do a whole semester, but I can't do that. So I've had to really be judicious about what I got rid of and what I kept, because we've only got 5.5 weeks. So this chapter is more of anatomy. We're going to talk about a lot of anatomy, things that you have in A&P that we don't have a lot of time to review, but just a little bit of time to review. So we talk about that, and then we'll be talking about care for women at various parts of the lifespan. Chapter 4, which we're not doing, is more GYN care. We just don't have time for that. You know, if I had a whole semester, I'd do the whole GYN care, but you know, this is OB, so we're going to skip chapter 4 because that's what it is. So, first slide is essentially the female reproductive system. You saw this in anatomy, but you are going to have to refamiliarize yourself with the female internal anatomy. So, number 1, we have the vagina, which is a muscular, hollow, collapsible tube. And then we have the uterus. This is the uterus, the whole body. The cervix is the door or the opening of the uterus. I always think about, tell students, the uterus is the house that the baby lives in. And the cervix is the front door. That's how the baby gets out. That's how the baby got in. That's how the baby gets out. So the cervix is the door or opening of the uterus. It's part of the uterus. The uterus has 3 layers. You do need to know these, especially the endometrium. The inner inside layer is the endometrium. Endometrium. Middle myometrium. And then outer layer is perimetrium. So inner, myometrium, middle, perimetrium, outer layer. What's significant about that? The endometrium, that inner layer, is what breaks down and sheds away each month as menses if the patient does not get pregnant. So we're going to be talking about the endometrium a lot in the first few days. So that's the uterus. The uterus is a hollow muscle that gets bigger and stretches and stretches and stretches because it holds the baby. It's normally smaller than the size of your fist if you're not pregnant. And it gets about this big, that term pregnancy. The fallopian tubes are attached to the top of the uterus. These are the fallopian tubes. The fallopian tubes have these little ends called fimbria, or fingers. I call them fingers, but the medical term is fimbria. And what it does basically, what this fimbria does, basically, this is the ovaries. The ovaries are attached to the uterus by the back. They're suspended and attached to the back of the uterus. Come out here. The ovaries are the hormone center in the body, and they release an egg every month. And that egg is pulled into the fimbria of the fallopian tubes. And when the egg is about in the outer 2/3, that's usually where it's fertilized by a sperm if it's going to be fertilized. So most pregnancies conception begins typically up in here. Now it can begin anywhere, wherever the sperm and egg meet, but 2/3 of the time it happens in the outer 2/3 of the fallopian tube. Ovary, fallopian tube, uterus, endometrium, myometrium, perimetrium, those are the layers. Cervix, which is the door of the uterus, and the vagina. Okay? So those are the things that you need to know. Those are the terms you need to be familiar with, able to see and define. I'm not going to ask you to fill it in on a chart. I mean, that's anatomy class. But we're going to be using these terms, and you need to be knowledgeable about when I say the outer 2/3 of the fallopian tube, you need to be able to see that in your mind what I'm talking about. This is just more of a straight on view and a side view. If you notice the side view, what's significant about this is that we've got the bladder under here's the uterus, the bladder's under it, the bowel is behind it. So if it's gravid, which is pregnant, uterus starts to enlarge, what's it going to fall down on? The bladder. So that's why in the first and third trimesters, pregnant women complain of a lot of frequency because the uterus is starting to get larger, so it's pushing down on the bladder. Also, the uterus right here can fall backwards and cause rectociliar things from the rectum as well. So those are problems that we see from the uterus. The uterus holds a place here. It's supposed to be here. So when we do hysterectomies, and this is not really pregnancy related, but let's say we do a hysterectomy on a patient, take out this uterus, it held a place here, and those things start to fall. So we get, everything falls when you get older anyway, and then you take out something that's supposed to be there, and you get a lot of prolapsing of organs in females especially. They end up having to have a lot of surgery to repair those prolapses. Especially if they've had a lot of children and their uterus is heavy and bigger than it should be because they've had a lot of children or had difficult deliveries. It can cause a lot of problems. External view of the female genitalia. Obviously, you see where the vagina is. This area you'll hear a lot about. This is called the perineum. From the bottom of the vagina to the rectum or to the anus is called the perineal area. And you can have a lot of tears there during childbirth, so you'll hear us refer to that. You have the labia minora, labia majora. Then you have the urethra, which is right above the vagina, and the clitoris, which is right above that. One of the hardest things to find on the pregnant women, especially if they just had a baby, is the urethra when you have to put a catheter in. There's a lot of trauma, swelling, bruising. So it can be very hard to find that urethra when you're dealing with a woman who just had a baby. Now this is the pelvis, the female pelvis, and we'll talk about this more when we start talking about labor. But this round area, obviously, this is the internal. There's a true pelvis and a false pelvis. This is the false pelvis out here, these iliac crests. Would make you think the pelvis is really big, right? Really wide. But if you look here, you see this is the actual true pelvis. This is how big the pelvis really is. Then the thing that makes the pelvis the most narrow, the narrowest most point in the pelvis are these two little knobs right here. This you need to know, called ischial spines. The ischial spines, these two little knob-like areas that project right here, and the ischial spines, that's the narrowmost point of the pelvis. So if a baby gets stuck coming down through the pelvis, they're going to get stuck at the ischial spines, more often than not. Also, that's how we measure what we call station. If we do an exam on a patient to see where the baby is, we can check dilation, which is if the cervix is dilated, which we'll learn more about later. We can check effacement, which is how thick or thin is the cervix. We'll learn more about that later too. And then we check the station, and the station means where's the baby's head in relationship to the ischial spine. If we get to go in and do an exam and we feel that the top of the baby's head is equal right here to these ischial spines, that's what we call zero station. You don't need to know that right yet. We'll know it later. But just remember that these ischial spines are the narrowmost point, and it's also our reference point for assessing position of the head. So it's the most narrow part of the pelvis, and it's our reference point for assessing position of the baby's head, in vertical up and down. Females can have different shaped pelvis. This is the four most common types. There are 6 or 7 types women can have, but by far, these are the more common. You do not need to know these, but I will say the most common is going to be gynecoid. And if you look at the diameter, which one do you think would be the worst for childbirth? If you look at the width of it, this one, yeah. See how prominent the ischial spines are? This is going to be the one you really don't want a patient to have because of that narrowing there from the ischial spines. This one's a little wider. That's gynecoid. That's a typical female pelvis. This is what we call an android pelvis, which is a little more like a male pelvis. And again, a little on the narrow side. And then platyploid is wide, but you've got a more very prominent coccyx back here. So you don't need to remember these types necessarily. I just want to point them out to you. And I also want to mention the coccyx. Everybody knows where the coccyx is, right? Back in the back. And it sort of protrudes down like that. And you might say, well, why doesn't that get in the way? Well, it doesn't, because what happens is the coccyx is attached by cartilage, and so if the baby's head gets in the way, the coccyx will just snap back and break. Oftentimes during childbirth, the coccyx will break. And it heals itself. You can hear it. Unfortunately, it makes an unpleasant sound, and it is very painful to the patient, but it heals and all's well. But the coccyx will not hold up the baby. It'll move right all the way because there's cartilage there, and it's a movable body. Whereas those ischial spines are not movable, and if the head gets stuck on those, it's just stuck. So a prominent coccyx, while it can cause a fracture, it's not going to impede the baby's progress. And then you've got a picture over here of the head coming down through the pelvis. And we'll actually, when we start talking about labor, I'll bring the baby and the pelvis in here, and we'll actually look at it so you can see exactly how the head's supposed to come down, and we'll kind of get a better feel for it that you can actually see it. But we're not there yet. We're getting there. Okay, so now let's back up, and we're going to start talking about pregnancy back from the beginning. In order for a pregnancy to occur, obviously, first thing we have to have is the reproductive cycle has to be working effectively. And that starts with menstruation. Menstruation, as you know, is a monthly discharge of blood from the uterus, and it's the endometrial lining that is breaking down and shedding away when pregnancy does not occur. Menarche, the definition of menarche means what age a person begins their menses. So what age a female begins menstruation. That's menarche, whether it's 12 years old, 13 years old, whatever the case may be. And then puberty is a broader term. Puberty, it can be male or female. The transition between childhood and sexual maturity. So menstruation menarche marks the beginning of menstruation. Often it's very unpredictable the first year, and a lot of girls will have anovulatory cycles, meaning they don't release an egg. So you hear stories about, I had sex at one time and I got pregnant. That is exceedingly rare. And I'm not going to say it's impossible, but it's highly unlikely. Because most girls have anovulatory cycles during their first year of periods. They're irregular, they don't ovulate very much. And it's usually the second year that they start getting into a normal rhythm. Now, the first day of bleeding, the day the period starts, first day of bleeding is day 1 of the cycle. That's day 1. And then the first day, so let's say then you start counting day 1, 2, 3, 4, 5, 7, 8, 9, and so on. And then the day that the next period starts, that's day 1 of the next cycle. So if you had 30 days, and then the next day your period started, that would be day 1. So you'd have a 30-day cycle. So from day 1 to the last day before bleeding starts again, that's the length of the cycle. Average duration of menses is about 5 days in most females. Average blood loss, believe it or not, I'm sure a lot of females will disagree with me, but the average blood loss ranges from 20 to 80 ml in total. As women probably say, oh no, that is not true, but that's the normal. Menses is composed of blood, mucus, and epithelial cells. And again, it's the endometrial layer of the uterus that is preparing a vascular bed for a baby. So the placenta can be formed and nutrients can be absorbed. So it's preparing a nice, good place for a placenta and a baby to grow. And if that pregnancy does not occur, then it breaks down and sheds away every month. Prostaglandin levels rise after ovulation. Ovulation means when the egg is released. So you can ovulate at 8 o'clock in the morning. Whatever minute the egg is released from the ovary, that's ovulation time. Now, we don't always know. Obviously, we can't see inside your body. But ovulation occurs at a moment in time. The minute the egg is released, that is ovulation. Prostaglandin levels in the female's body rise after that, and that causes the uterus to contract a little bit. So always associate the term prostaglandin levels with contractions or tightening of that uterine muscle. And that contraction during ovulation propels sperm, if the sperm are in the body, to move forward and enhances the possibility of the sperm getting to the egg. So there are a lot of things in the body you're going to learn that are in place to enhance the possibility that a sperm and an egg can meet. So, our bodies are made to encourage and enhance pregnancy, not to discourage pregnancy. Okay, there are several events that, like I just said, that occur around ovulation to enhance that possibility. First of all, when the egg is released from the ovary, viable for about 24 hours. So if the patient ovulates at 8 o'clock this morning, the egg is good, and the egg is able to be penetrated by the sperm for about 24 hours. So 8 o'clock this morning, 8 o'clock tomorrow morning, let's say. Other things that happen, the cervix becomes soft and dilates just a tiny bit due to that prostaglandin, and that allows sperm to get into the cervix easier, because remember that cervix is the door, so it opens the door just a tiny bit so the sperm can get in better. As I said, ovulation represents monthly release of the egg. Cervical mucus becomes thin and copious with the consistency of egg white, and again, that just becomes a medium that is hospitable to sperm. There's a slight change in the pH in the vagina so that it's more hospitable to sperm. Normally, pH in the vagina is extremely acidic, like 4 to 5, very acidic. Why do you think that is? Why do you think the female vagina normally would be so acidic?
Cleaner.
Well, it protects against bacterial invasion. So it kills a lot of bacteria by having a very acidic environment. Now, exactly. The vagina is there's not anything you can do in this world to make a vagina sterile. I tell you that. If you don't remember anything else, remember that. It is not sterile. Now, it also, a pH of 4 to 5 is not really very hospitable to sperm. It will kill sperm. So one of the things that happens is that there's a pH change that occurs around ovulation to bring the pH up a little bit so it's not so inhospitable. The other thing that happens is the male, something's released by the prostate gland in the ejaculate, in the semen, that is very base. So it kind of counteracts the acid. It kind of neutralizes the acid. So, there are some couples who, for whatever reason, maybe they do a semen analysis, find that that male doesn't have that, or his semen is not very base. And so then, it's the acid from the female vagina that's killing the sperm. So there are a lot of little things like that that can affect pregnancy. But in a perfect world, the male counteracts that acidity from a fluid that's released by the prostate. A few women will report a sharp abdominal pain when they ovulate. They feel it on one side or the other. If a woman does that, that's great. All women don't do that, and you can't actually count on it, but there are some women who say that they feel a particular pain. Also remember that if the left ovary releases an egg this month, the right ovary releases an egg next month. Left, right, left, right, left, right. So you don't ever know which one is releasing the egg, but it is one or the other. Now, let's say you had surgery and you had an ovary removed. What does that do to your reproductive capability? Cuts it in half. It cuts it in half. You've got half the reproductive ability. You can only get pregnant every other month, and you don't know which month it is, unfortunately. So, you don't want to lose an ovary if you can keep from it, because yes, it's good to have one, but it's better to have two in terms of conception. Also, if we check a woman's body temperature, the basal body temperature dips slightly immediately after ovulation and then spikes. So for a lot of women who are trying to achieve pregnancy, we will have, or for women who are using natural methods of birth control to try to prevent pregnancy, we have them check their basal body temperature, and when they see that dip and spike, they know they're ovulating sometime in the 24-hour period. So basal body temperature means the temperature of the body before you get out of bed, before you roll over, turn your clock off. As soon as you open your eyes, you have to take your temperature right at that moment. If you get out of bed first, it will not be accurate. So basal body temperature is the lowest the temperature is right as you wake up in the morning. It has to be taken really accurately to be correct. All right, we'll make this the last slide. It's about low. Okay. Oh no, there's no way I can do that one. Forget it. That's going to take me 10 minutes. This is where we'll pick up on Monday, right here. I can't get into that one. Okay. Stacey, that's it. I'm going to log you off. We're done. We'll pick up here on Monday.
Stacey was asleep.
Honestly, weird.